Good. I hope everybody had a very good Thanksgiving. And anyway, we're about to have another, hopefully wonderful Residents Present. And in this time of COVID, it's particularly important because new residents don't really get a chance to meet other people, and we don't get a chance to meet new residents. And a relatively new resident is Susan Nemens. And she came about a year ago. And so some of you have had the opportunity to meet her, but after we got locked down, all that stopped. So anyway, I'm delighted to introduce her today. And Susan was born in Washington and grew up in Maryland. She graduated from the University of Maryland in College Park, and then University of Maryland School of Medicine in Baltimore. She trained in pathology at NYU Bellevue Medical Center in New York and practiced pathology in New York, London, New Jersey, and Pennsylvania. She spent several years doing clinical research for Armor Pharmaceutical and for Pfizer in the fields of immunology, hematology, and cardiology. She was married for over 40 years to Doug Nemens. He sadly passed away in November 2013. She's got two daughters, Kate, who's an attorney who lives in Jamaica Plain with her husband, and Kate and her husband have two daughters, Eliza, who's 11, and Zoe, who's aged 8. And her second daughter, Deborah, lives in Seattle and is a field biologist at the University of Washington. She retired from pathology in 2013 and moved to Newbridge in February of 2020. So actually, she's not actually even been a year here. And she's going to talk to us today about the body in question. And she actually probably is running for president because she wanted to point out that the title is plagiarized from the 1986 book of the same name by Jonathan Miller. Anyway, Susan, it's all yours.
Well, all I can say is thank you for that lovely introduction, and let's push on. Okay, good afternoon. Thank you, Michael, for that very kind introduction. And I'd like to introduce what I'm talking about this afternoon. The title is The Body in Question. The Body in Question. The reason I picked this title is that when Michael asked me to talk about what I did while I was working before I retired and moved to Newbridge, I thought that since I was a pathologist, I would talk about bodies. It seems reasonable to do that. A lot of people don't really know what a pathologist does. Most people think they know what a surgeon does and what an internal medicine specialist does, what an orthopedist does. But what does a pathologist do? Do we do autopsies all day long? Well, the answer to that question goes back in historical times. Pathologists were kind of akin to chemists and alchemists. In this case, this is one of my professional ancestors. This is my Uncle Arthur in his laboratory in the 1400s, and he was trying to turn base metals into gold. Didn't work. But as we evolved, we got a little bit more scientific, and we figured out ways of becoming medical detectives. So I would consider that what pathologists do is solve mysteries, solve problems, and act as medical detectives. And I think we do a lot. Here's some of the things we do. We look at tissues, both from the living and from people who are deceased. We look at them in the natural state and under the microscope. We also look at other things under the microscope, blood cells and fluids. We do blood tests and we use all kinds of laboratory machines. And it seems to me that we do a lot. Fortunately, when I went into the business, I had a role model in the person of Jonathan Miller. Jonathan Miller, most of us will remember, he died last year in 2019. He was a producer of operas. He was a zany comedic actor in a satirical group based in London called Beyond the Fringe. But before all that, he trained in medicine. He has an MD, had an MD, and he trained in morbid anatomy, which is what they call pathology in Great Britain. Here he is with his confreres, Peter Cook, Dudley Moore, and Alan Bennett in Beyond the Fringe. I'm sure a lot of you remember him and remember the people in Beyond the Fringe. They were really very funny guys. One of the things that Jonathan Miller did, he was a polymath. He swung back and forth from the arts to the sciences with great ease. And it gave me heart to go into the sciences or to go into medicine, because I figured that if it was good enough for Jonathan to do morbid anatomy and then to be interested in the arts, it was more than good enough for me. This book, The Body in Question, was published in 1986, which is quite some time ago. He made a television series out of this book called The Body in Question, from which I plagiarized the title of my talk. He was doing all kinds of exposés of how science helps diagnostic techniques. And he went through an autopsy. He picked up hearts in his hands and showed them to the audience. And it was kind of an inspiration for me. When I first entered an autopsy room, I noticed above the door, there was a quotation from an 18th century physician, Giovanni Morgagni, and it reads as follows: "Let conversation cease, let laughter flee. This is the place where the dead or death delights to help the living." So as pathologists, we do study death. I'm trying not to make this talk morbid, but it does deal with occasionally with people who have passed away. First, we look at the organs with the naked eye without a microscope. Then we cut into the organ to examine its cut surface. Then we look under the microscope, and finally we do more advanced technologies, including immunostudies and molecular techniques. Let's go from the head down to the toes, and I'll give you a sort of a bird's eye view or a potpourri of the kinds of things that came across my desk or my table when I was in practice. We'll start with the brain. In this case, we have 4 separate brains. The cerebral cortex is the large globular structure that seems to contain wormy brown tissues separated by canals or empty spaces, or rivers, if you will. The cerebellum is the small blob that's underneath the cerebral cortex. And in the top left-hand slide, you can see the spinal cord. These are 4 brains taken from supracentenarians, that is, people who lived well past 100, pretty hale and hearty, lively people, died of natural causes into their hundreds. In no case are there abnormalities in these brains that we can see grossly. These people did very well in life, and for whatever reasons, longevity was in their genes. They were lucky enough to live past 100, and their brains aren't much the worse for it. I don't know what any of these people died of, but they were natural causes. In contrast, I have a picture of the brain of a person who died with dementia in Alzheimer's. You can see that the islands of tissue, the wormy brown things, are much reduced in size, which we call atrophy of the brain. And the spaces between the gyri, which are the tissues, the spaces are called the sulci, and they are much widened. So you can see the cerebral cortex, and underneath it, the cerebellum, which is mostly concerned with movement. The cerebral cortex is what we attribute thinking to. It's been atrophied, and that goes along with Alzheimer's and with dementias of various kinds. Okay, moving down from the brain, we'll go to the heart and the lungs. In the middle, we have the heart with a big X on it, and to the right and the left, the lungs. The right lung is on the left, and the left lung is on the right. The right lung has 3 lobes, and the left lung has 2 lobes. The chamber of the heart with the X on it is the left ventricle, which is responsible for pumping blood all around the body. The great vessel that emerges from the left ventricle of the heart, which carries the blood in its oxygenated state to the various organs of the body, is the aorta. And from that aorta, you see 3 tubes emerging. Behind the aorta looks to be the bronchus, main bronchus, which divides into 2, left and right. The smaller arrows, the fatter, smaller arrows, but not the skinny arrow, denotes the pulmonary blood vessels, pulmonary arteries. The pulmonary arteries arise from the right ventricle of the heart and take blood from the heart into the lungs to be saturated with oxygen from the lungs. The left ventricle takes the oxygenated blood, usually represented as something pink on drawings of the heart, to the various organs of the body. In this case, there's a medical mystery which we can solve rather readily. In the middle of this photograph is a big, blobby, shiny, jelly-like mass, which is an embolus. This is the cause of death in this patient. On the left and the right are the spongy pink lungs. The blood supply has been cut off to them, and the patient stopped breathing and went into cardiac arrest because there was a clot that moved from some other part of the body into the lungs. It moved north. A lot of times these clots come from what we call deep vein thrombosis, in which the veins of the legs have blood clots in them. In other cases, sometimes after surgery, in the pelvic blood vessels, these clots form. They're called a thrombus. And then when they travel up to the lungs, an embolus. You can get an embolus in the brain, you can get one in the lungs, and pretty much anywhere else. In this case, the blood clot is referred to as a current jelly blood clot because the old pathologists who named these things and discovered these phenomena were always thinking of food. It was called gastronomic pathology in those days. Anyway, this is a current jelly blood clot. It stopped the blood supply to the lungs, it stopped breathing, and the heart stopped. Here's the heart again in a drawing. As I said, we usually represent arteries in pink and veins in blue because the arteries have oxygenated blood and the veins have less oxygenated blood, and therefore they're just rendered as blue. You can see the pulmonary blood vessels coming out of the heart in blue, the aorta, the main artery of the body, which takes blood all over, including the brain, in pink. The vertical artery that's on the surface of the heart here, as shown by the big fat arrow, is the left anterior descending coronary artery. This is the blood supply for the heart, the main blood supply. There are other coronary arteries, but this is one of the biggies. And if you get a clot or some sort of obstruction here, the blood supply to the heart is compromised. The ventricle, which is tasked with pumping blood around, doesn't pump very efficiently. And you get a coronary occlusion and a myocardial infarction, which we'll see in the heart next. Here's the heart. You can see a wormy kind of currant jelly blood clot, shiny purple blood clot at the end of the arrow. That stopped the blood coursing down the left anterior descending coronary artery. The blood supply to the heart was compromised, shut off. And at the bottom of the photograph, you can see a discoloration in the heart. That part of the heart muscle died and took the life of the patient. These days, people die much less often from coronaries because we have a lot more scientific ways of studying and treating these occlusions. Coronary angiography, cardiac catheterization, removal or dissolution of the thrombus, placement of a stent to increase the blood supply to the heart, and coronary bypass. Now, in this particular case, I'm showing an enlarged heart. In this case, the heart, when it comes to the heart, bigger is not better. The normal heart on the left is normal size, and the one on the right is enlarged. Why is this heart enlarged? It had trouble pumping blood around. Either the heart muscle was compromised, the person had so much high blood pressure, such severe high blood pressure, that the heart couldn't effectively get the blood out. It got larger and thicker and tried to work harder and harder, but was not able to pump the blood around, and it failed. One of the consequences of cardiac failure or congestive failure is seen in the liver, which I'll show you presently. Here is a normal liver removed at autopsy. It's uniformly brown. It's got two lobes, a larger and a smaller one, right and left, separated by a ligament. The liver is a factory. It detoxifies poisons in the blood. It detoxifies drugs, which the patient is taking. And it just is an incredible factory of biochemical reactions. In the normal state, it chugs along and does its work. When the heart is compromised and the circulation is compromised, sometimes it becomes congested. This is a section of liver, not to channel our inner Hannibal Lecters, but this liver looks pretty much like a calf's liver that you would cut into when you're cooking liver and onions. It's very recognizable. It's uniformly brown. And the holes that we see in this picture are blood vessels. Here's another example of gastronomic pathology. This is called a nutmeg liver because it looks like a nutmeg, which I'll show you in just a minute. It's congested, very severely so. These red lines are channels filled with blood between the liver cells. The congestion interferes with the functioning of this little factory, and it's a diseased liver. This can be reversed by fixing the hemodynamics of this person's system, but right now it's a congested liver. It's not up to par. It's not doing its work properly. Here's the nutmeg after which this pattern was named. You can decide for yourself whether you think the nutmeg liver really looks like a nutmeg or not. Let's go back and check this once again. It sort of resembles a nutmeg with the eye of faith. But anyway, this is a nutmeg liver and it's chronic passive congestion. The liver cells are getting sicker and sicker. In this case, there's a normal liver on the left, and on the right, we have what we call a fatty liver. The liver cells, the little factories that I was talking about, are replaced by fat. This is one of the earlier steps towards getting a diseased liver. Fatty liver is often seen in alcoholic malnutrition when the liver is replaced by fat, and it can be seen in cases of malnutrition and in other diseases. Under the microscope, you can see how the liver cells are replaced by fat, which are represented by these things that look like holes. If you look in the upper part of this photograph and also in the center, you see these sort of polygonal shaped pinkish purple cells, which have a grainy sort of appearance and also contain a dark purple nucleus. The fat is washed away during the fixation of the tissue and the processing of the tissue and leaves empty holes. So the empty spaces that have no color at all are the fat. The fat, when it replaces the functioning liver cells, isn't doing this liver any good at all. It might be functioning at half capacity if it's doing well, but you can imagine that a liver that's half replaced by fat isn't going to function too well. And so it doesn't. Moving along in this disease process, we come next to liver cirrhosis, which usually, as I indicated before, is associated with alcoholism, alcoholic cirrhosis, and malnutrition. The little nodules are what's left of normal liver tissue, which has been largely taken over by scar tissue. So this liver is nodular. It can be felt, can be palpated. It's certainly obviously seen on the gross specimen from this autopsy case. And under the microscope, under low power, we can see nodules, which accounts for the nodular appearance of the liver. There are broad bands of purplish scar tissue in between the lobules of the liver. Some of these nodules or lobules, I think nodules is the more proper term, are large and some are small. You can see what we call macronodular or micronodular cirrhosis. But in any case, the nodularity is definitely a sign of illness, sickness in the liver. Here's nodular cirrhosis, in which the liver nodules are of various sizes. There's a macronodular nodule in the middle of this photograph, and somewhat to the left, a micronodule. They're all surrounded by fibrous tissue, collagen, scar tissue. In this case, the scar tissue is delineated by a blue color or indicated by a blue color. This stain is a trichrome stain, which emphasizes the scarring in contrast to the normal or relatively normal functioning liver cells in the nodules. The worst case scenario is when a tumor arises in a liver that's cirrhotic. This is a hepatocellular carcinoma. It's a primary malignant tumor in the liver. The normal liver surrounding this big white nodule is relatively, well, it's quite normal in appearance, this mahogany brown appearance with blood vessels that look like holes. The hepatocellular carcinoma is a very unfortunate consequence of cirrhosis. And cirrhosis, as I said, is often seen in alcoholism, but it's also part of the later stages of a hepatitis infection. So a diseased liver, which has been attacked by hepatitis virus, either Hep B or Hep C, can develop cirrhosis over time. It does take quite a few years. And it can also give rise to a hepatocellular carcinoma. So, as I said, nutritional or alcoholic cirrhosis is one of the causes of alcoholism is one of the causes of cirrhosis. Hepatitis B and C also. Now, in current times, hepatitis C is curable with the appropriate drugs. Drugs have been developed over the past couple of decades to inhibit viral replication, so the virus can't reproduce itself and attack the liver. This cure of hepatitis C is a wonderful milestone in medicine and has really saved an awful lot of lives. They fall into the categories of inhibitors of certain enzymes in the viruses, protease inhibitors, polymerase, and reverse transcriptase. But suffice it to say, these drugs are inhibitors of viral replication. Here's the gallbladder tucked very cozily under the liver where it lives. The liver secretes bile by means of a cystic duct. The bile goes from the liver into the gallbladder for storage. It then is released into the intestines and aids in digestion. And here's a liver with gallstones. If any of you have had a gallbladder attack or a gallbladder removal, you'll be familiar with this phenomenon. This gallbladder is inflamed and scarred and really messed up, and it's full of gallstones. In this case, the gallstones are yellow and they are made of cholesterol. These are cholesterol gallstones. This person and all the people whose livers I showed you before could well have had jaundice. This is jaundice of the sclera of the eye, and it's certainly a clinical sign of a diseased liver. Here's a case of neonatal jaundice. This is a newborn baby who came out yellow. And the reason for the yellow coloration and the jaundice in this child is that the liver was immature. Usually the liver will become mature and be able to do its function in a couple of days or so. This baby was treated with light and became perfectly normal in a couple of days. One of the other things that we do as pathologists, besides looking at organs, is looking at blood. The poet Rainier Maria Rilke stated, "All the soarings of my mind begin in my blood." Well, maybe so. We'll see. Here's a smear of blood taken from a finger stick. The blood was smeared on a slide. It was stained appropriately and examined under the microscope. This is perfectly normal blood. The red circles, or they look like circles with a pale middle, are red blood cells, of course. The very small little purple object in the upper left is a platelet, and the big sort of blobby purplish pinkish cells are white blood cells. They come in various flavors, and they all help to fight infection. Here's a scanning microscope study of red blood cells. You can see they are not spheres. They're biconcave discs. So they're discs with a little patching in the center. The job of red blood cells is to carry hemoglobin, which carries oxygen to the tissues. Here's a slide of a person who came from India. He went for a visit with his mom. He must have forgotten to take his quinine pills because he came back with chills and fever. His mother brought him to the hospital where we looked at his blood and saw that he had malaria. The malaria parasites are within the red blood cells. They are ring-like forms and they are purplish in color. Some of them look almost like a signet ring. The unaffected blood cells are without these parasites. The parasites grow inside the red blood cells and get to be so big that they burst the cell and cause hemolysis, which can result in jaundice and certainly results in chills and fever. It can be fatal if not treated, but we have ways of treating it. So it's an annoyance in this country, and it's much more than that in tropical countries where the mosquitoes that transmit the organism thrive. Here's a little guy that we used to see on Monday mornings in the hospital with great regularity in the summertime. I was working in Westchester, and people in Westchester would go to their country homes and on the weekends and on Monday mornings come back with these little fellows in plastic bags asking if we could identify them and should they be worried. In this case, this is a deer tick, and they should be worried. Some of the patients came down with a bullseye rash, which is pretty diagnostic for Lyme disease. I've had this so many times I can't begin to count. And fortunately, we have a treatment for Lyme disease if it's caught early. This is the organism that causes Lyme disease, transmitted by the deer tick, Borrelia burgdorferi. It's called a spirochete because it looks spiral in shape. And now, coming to the end of this presentation, I'll show you some fluids that we look at in the laboratory. The first one is a fluid that contains crystals that look like spears or needles. And just looking at them is actually rather uncomfortable, if not painful. This was taken from a toe or another joint in a patient with an inflamed joint. Here's a picture made probably a couple of 100 years ago and depicting what gout feels like. I wouldn't know from personal experience, but it looks most unpleasant and has been described as really excruciating in sufferers. Here's a patient with gout. In this case, it's afflicting the elbow. It's red, it's warm, it's painful and swollen. What else could you possibly ask for? And on sectioning, if this is removed from a person's limb or toe, it looks like a chalky deposit within the tissues. Fortunately, we have treatments for gout. It used to be considered an ailment of only the wealthy and well-fed, but now we know that it's often hereditary. However, if eating foods that are rich in purines, such as sweetbreads and thymus, can exacerbate gout. It involves an increase in the level of uric acid in the blood, and that's certainly a diagnostic measure also. Let's see. Including, as well as foods that are have a high content of purines, beer with brewer's yeast and high fructose corn syrup are also implicated in exacerbating gout. Here's a person, a college student who arrived at Cornell in Ithaca, got headache and a stiff neck, presented to the emergency room, had a spinal tap or a lumbar puncture, and pus cells were found in the spinal fluid. If you remember way back when I showed you the blood smear, you saw red blood cells and you saw white blood cells. These are white blood cells. They fight infection and they accumulate by chemical signaling within the body to a place where there's an infection or an inflammation. In this case, it's meningitis. There was an organism in the spinal fluid. The white blood cells rushed to the scene and were diagnostic. The organisms were found and the patient was treated appropriately. Okay, this is a more ominous fluid, which was taken from the chest cavity in a woman with breast cancer. These are the cancer cells as shown with the arrow. They're large and ungainly cells in a background of smaller, well-behaved cells. They are diagnostic of a cancer, not necessarily from the breast, but certainly if the patient has breast cancer, most likely from that same tumor. It's seen in the pleural fluid, or the fluid surrounding the lungs, which was taken out by needle and presented to our laboratory. I believe that's the last one, yes. I thought I'd end on a more pleasant note of sunflowers after we've seen all these organs and tissues and fluids. Thank you for paying attention, and I hope you were amused as well as enlightened.
So thank you, Susan. That was fabulous. So I'm sure there'll be lots of questions. So if you'd like to indicate, Anne, you've got a question. You're muted. Can you unmute yourself? You are muted.
Yes, okay. When a baby is yellow jaundice, they put him under a sun lamp. Why that,
It
Susan?
helps to dissipate the toxic bilirubin, which is a product of red cell breakdown and metabolism. One of my kids had it, and she was just put under a lamp, tush up. Gesundheit. Facing
Thank you.
with her tush up in the air for a
You
couple
better-
of days. If this doesn't work, you have to get more radical, but in most cases, this light, I'm not sure what the chemical reaction is, but it dissipates the bilirubin. If bilirubin gets into the brain, there are bad consequences. So you really want to get it lowered.
And you have to delay the bris if the baby's jaundiced.
I'm sorry, what was that?
You have to delay the bris. You can't do a bris.
Oh, the bris.
Yeah,
I thought
because until the baby's normal. So.
Okay. Do any of the MD types around here know more than I do about why light works to deal with neonatal jaundice?
I'll have to check. No, I don't know.
There must be some good reaction, but
Right. Yeah. So, other questions? Sam.
Yes. Well, that was very nice about easily diagnosed problems. Have you ever had anything that you were not able to diagnose, some new kind of observation that does not fit into this pattern of what you've shown us?
of course, many times. I was in practice over 40 years, of course. One interesting case, I was working in Westchester County, and a young prisoner in his 20s, this was back in about 1981, something, came into the hospital and had this weird pneumonia, this organism that usually didn't attack anybody healthy. Turned out it was, the guy had AIDS. It was one of the first cases, and we saw the organism and couldn't figure out why he got it, but later it became clear when a number of cases were discovered with the same sort of thing. A guy 25 years old comes in with this weird pneumonia, dies within a day. So that was a puzzlement. I didn't make that diagnosis. One of the infectious disease guys did. He set up a microscope in his office, and the people were lined up around the block trying to get a glimpse of this organism. But yes, the answer is absolutely.
So I quickly checked with Dr. Google. And Dr. Google said that the way that light works is that the bilirubin is unconjugated. Therefore, it is not water soluble and cannot be excreted. And so the light leads to photooxidation of the bilirubin, which enables it to be excreted in the urine. And therefore, the bilirubin falls.
Thank you, Dr. Thorner, and thank you, Dr. Google.
Anyway, Terry, I think you had a question. You're muted.
I said, someone is on the phone and they need to turn it off because it's disconcerting. So I had a question about the I don't know who's talking about the stones in the liver. I was kind of surprised to see how many there were. Always thought of, or like kidney stones or liver stones, that they were maybe a couple of stones.
That's my mistake. I meant to say gallbladder. That gallbladder was full of stones. Usually they're just a couple, but I've seen cases where there were just too numerous to count.
No,
they're not in the liver, they were in the gallbladder. That was my error.
Well, no matter where they were, I was just surprised to see there were so many.
You can have one, a great big one that takes up the entire gallbladder, or you can have 100.
So don't they sometimes want you to pass those? Or is that kidney stones? There's so many different kind of stones.
Usually, I think you're thinking of kidney stones.
Kidney
They
stones.
can be zapped with lasers as well. But when the gallbladder fills up and starts to get really obstructed, it's time to take it out. And people can survive nicely without them. So
you remove the gallbladder and then it's.
yeah, it can be taken out by laparoscopic surgery. So you're just left with a teeny weeny little scar. So it's
Interesting. Yeah. Okay, thanks.
you're welcome.
Marlene?
What do you stain the slides with to show the cells?
The stain we use usually is called hematoxylin and eosin. And hematoxylin stains tissues that are fixed appropriately a sort of a purple color, and eosin a pinkish color. So you can delineate the nucleus from the cytoplasm and so forth. Yeah.
What is that fluid?
The fluid,
The stain?
it's a vital stain. It was invented decades and decades ago. It's been with us for a really long time. I'm not sure what hematoxylin or eosin are chemically, but I can, if you need to know, I can ask Dr.
No. Okay. Thank you.
Linda has a question.
Thank you. Years ago, Susan, I remember that there would be discussions about autopsies and whether one should have one or one's loved one should have one or not. Did you see a change in that over the years with more autopsies being done because of, and why do you think that changed? Was it doctors recommending them? Was it appealing to science?
Okay, that's a really great question because basically we now see fewer autopsies than we did before. People are a little bit superstitious and didn't like the thought of having their loved ones kind of cut on after death. And the reason they consented to autopsies, and you had to have consent, written consent legally, was that the doctor usually needed to know something, really wanted to know, and suggested to the loved ones that this would help advance science. So that was the main reason. Now we have so many kinds of scans and so many kinds of amazing tests that the answers can be figured out well before the patient passes away. So there aren't that many questions, or at least in the minds of a lot of practicing clinicians. So the rate of autopsies has dwindled, at least in the time I was in practice. I don't know what's going on now since I retired, but they are much fewer than previously, and also mostly in academic centers and community hospitals. You don't see too many people requested.
It used to be that when I did my training, that going to the autopsy, which was done every week, there was an autopsy conference where cases were presented, was actually the way that one really learned about disease processes, and one understood which organs were involved and how that affected the organs and so on. And over the years, the number of autopsies went down dramatically, and the American Board of Internal Medicine requires that there be autopsies done for training in internal medicine. But it's sometimes quite difficult to do because you don't have patients who have or families who've consented to that. So it's been, in a sense, as Susan says, an advance that we know so much more about why somebody died before they died. But on the other hand, it's actually interfered with medical education, doing fewer and fewer of them.
True.
Also, in some religions, like Judaism, you can't have an autopsy.
Correct.
Yeah.
That's absolutely right. I don't think the ultra-Orthodox like autopsies one bit.
Mm-hmm. Right.
Are there other questions?
Yes. I don't know if you're waiting. Did you ever do forensic pathology? And if so, will the manner of documentation change from your earlier years to your later years based on technology and science?
The answer to the second question is yes, everything has advanced and changed with technology and science. I only did a couple of forensic cases during my training in the medical examiner's office in New York, which was run by the famous or infamous Milton Halpern. There was another medical examiner who became famous too. I think he testified in the O.J. Simpson trial much later. I'm trying to remember his name. It's not coming to mind. But anyway, I didn't do much forensics. It's a really very specialized area of pathology. So I did just minimal amount of training in forensics. It could be a little bit gruesome. Most of the time, the deaths were violent or unnatural or unexpected. So, you know, accidents and stuff like that. It wasn't my specialty.
Sam, did you have another question?
Charles had a question.
I wanted to say, I read a couple of years ago that medical students are not going into pathology because there's a concern about job availability. You know anything about that?
There were a diminishing number of jobs available as I went through my professional life. But I'm not sure what the reason is. I think maybe too many pathologists were being trained for the number of positions open. I think it was just a market conditions. I'm not aware of any other specific reasons for that.
Linda?
I remember hearing years ago that certain personality types went into certain types of medicine. Oh, could you tell us more about that? what would attract you, or what did attract you to pathology?
Well,
or maybe you don't want to answer that. I don't know.
I have to leave that to your imagination. But people who are shy and not social butterflies tend to go into pathology because it's quiet and you don't have to interact with patients. In my case, I wanted regular hours. That was more or less the case. Not too many emergencies between midnight and 6 in the morning. But yeah, it's true that people who are a little bit shy, shall we say, are the ones who tend to go in for that specialty.
Susan, Charles has had his hand up for a while.
Oh, sorry,
Susan.
Charles.
Susan.
Yes, yes.
What do you have a favorite, a case that you think is you're the most interesting or the most, gave you the most pleasure or gratification? Do you have a case that you can tell us about?
Gosh. I have to think about that for a while. Nothing pops into my head. There was one case in which let me think. It was a surgical, okay, I was doing frozen sections, which is diagnosis of something during the surgery. The surgeon handed us a liver, part of a liver, which had a capsule. And inside it was a bunch of worms wiggling around. And I had never seen anything like this. Fortunately, one of my colleagues was from India and she said, oh, that's such and such a, round worm. We see it in India all the time. So it was a memorable case because I had no idea what it was. And she knew.
The parasite.
Some horrible worm, whatever.
My question is, now that you're retired, are there any technological advances that would enable pathology to be conducted on living persons before they,
Well, one area that I think is very exciting and I don't know enough about or not much about is the specific molecular configurations, or I guess you'd say genotypes of cancer cells. So we all know that cancer cells are just run amok, and genetically they're screwed up or out of control. But the very specific genetic modifications are leading to very specific chemotherapies. Instead of bludgeoning the body with a, scorched earth drug that makes everybody sick, or the person who's taking it, we can now be much more specific and more focused on the tumor, and the chemotherapy won't bother the other cells. So that's one of the huge advances since I've been working. Yep.
Thank you.
Thank you.
So, are there any other questions?
Yeah, just a comment. Well, talking to a pathologist I knew, the other two reasons he went into pathology was his patients didn't talk back.
They don't.
And his malpractice premiums were very low. But you are talking about doing some different research, so it comes out a little bit differently. Or do you work directly with the patient, or it's handed off to you by the treating physician?
Well, in my case, my patient contact was limited to doing needle aspirations. I don't know if you're familiar with that, but if somebody has, let's say, a growth or a tumor somewhere that's accessible. Oh, can you hear me?
Yes.
Yeah.
So my phone is ringing, but it'll stop if you can ignore. I've just got a robocall on my other phone.
Who's that?
We can all mute.
It's going to go away, I promise.
Somebody.
Done. Okay, so usually I got specimens, shall we say, for want of a better word, in the laboratory from the clinicians who wanted an answer. But also there's sometimes pathologists go to see a patient and they can stick a very thin, very skinny needle into a tumor, let's say, on the surface or even inside in one of the organs, pull out some cells and make a diagnosis. But that was the limitation of my contact, except I worked in women's clinics sometimes, diagnosing cervical cancer in various populations, and so we did patient education. But in general, I was a secondary player in the drama.
Marlene?
Is it pathologists who are determining DNA? People are going to ancestry.com and 23andMe.
No.
Who does that test?
Not pathologists, it's geneticists, I would think.
Oh, genetics.
Sam? You're muted.
Just a specific question. On one of your slides, you showed two hearts, one diseased, I guess because of lack of blood flow to clots or something, and it seemed to be quite enlarged. And I wondered why does that happen? Why is the heart muscle increase when you have such a trauma?
I think.
Does anybody know? Because I've been interested in muscle.
Well, the heart is a muscle, there's no doubt about it. Just think of pumping against a blockage, high pressure, too much pressure, and you're pumping against the pressure. The pump works harder and harder and gets bigger and bigger, but it isn't able to pump the fluid past that obstruction.
So do you
do any gardening work with a hose or something? You try and squirt water through a hose, and there's a.
So do you think that's like stimulating muscle growth, just the way skeletal muscle gets bigger if you do the weight training, a similar kind of phenomenon?
I don't know if it's the same exact mechanism, but yes, muscle gets bigger. Each cell, each fiber gets larger and larger.
So Sam, the reason the heart can get bigger is two reasons. One is, as Susan said, if there's obstruction. So if you have aortic stenosis, you'll get cardiac hypertrophy, which is the heart will get larger to get stronger to try and overcome the obstruction. Similarly, in patients with bad high blood pressure, they will tend to get a hypertrophied heart. And the other is when the heart can no longer manage to pump the blood properly and it dilates, and that's a dilated cardiomyopathy. So they're two different sorts, but and then you can also get an aneurysm in the heart if you have an infarct and then the muscle basically dies, and then you just get connective tissue, and it blows out.
Interesting.
So I think that our time is coming to an end. I'd like to thank Susan for fabulous Residents Present, and again welcome Susan to Newbridge.
Welcome and thank you.
Thank
you.
Thank
Yeah,
you,
it
Susan.
was great.
Good to be here.
It was really great.
Thank you.
And next month, in December, it's going to be on the 18th, because the usual last Friday of the month is December 25th. So there won't be one on that day. So we're going to do it on the 18th. And Carol Houseman, who is also new to Newbridge, and she is a clinical psychologist interested in geriatrics, has done some pioneering work of working with older people, particularly in the Jewish environment. She's going to tell us about her work and also about a course that she's planning to put on. And we're looking forward to that. And that will be on December the 18th at the usual time. Anyway, thank you all.
Thank you.
Enjoy the rest of the weekend.
Goodbye.
Thank you.
Good
Thank
Shabbos.
you.
Okay, bye-bye.
Thanks.